was reported. You can see the beautiful shores of the French Riviera there. This was the actual weather with a unseasonable snowstorm, and altogether not as advertised. But what came out of it was the newest report from the Sixth World Symposium on Pulmonary Hypertension that has changed our thoughts about diagnosis and treatment of PH. Just a brief history of why the World Symposium exists. World Symposia on PH were typically formed around pulmonary hypertension crises due to diet pills. So back in 1973, the first World Symposium was held in Geneva by the World Health Organization, and really in an effort to describe a new disease of pulmonary hypertension that was due to the diet pill called Aminorex. And at that time, the classification that was agreed upon was primary pulmonary hypertension, which is an old-fashioned way of saying PAH or group 1 PAH, and then the secondary or associated cause of PH that you all know, secondary to heart disease and lung disease. It was at that time the hemodynamic definition of a mean PA pressure greater than 25 millimeters of mercury came into play, and that's going to become important here in a few slides. Nothing really happened for a good 25 years until the next diet pill craze came around, and that was the fen-phen craze in the late 90s. At this point, another World Symposium was held in Switzerland in 1998, and this is really the contemporary start of the every 5-year series. At this point, we had calcium channel blocker therapy available, and epoprostenol had just gone through clinical trials the year prior. Calcium channel blockers is a little bit earlier in the 90s. And during this meeting, pulmonary hypertension was then classified into the 5 World Health Organization groups that you know of now. And this meeting was really held to guide and concentrate research moving forward, as there were now drugs coming on the market. 5 years later in Venice, there were now all 3 drug classes that you know about available at that point. So the prostacyclins in terms of epoprostenol was already there. PDE inhibitor therapy as well as endothelin receptor antagonist therapy was available at that point. And given that there were multiple medications available to treat at that point, the first treatment algorithms were made. Also, classifications are always being redefined as we understand more and more about each disease state. And in 2003, the first genetic cause of familial PAH was discovered in the BMPR2 mutation. In 2008, this was held in California, new management strategies for early disease were developed at that time, functional class 2 disease. This is where we began to deal with goal-oriented treatment or endpoints of therapy, as well as the focus of further randomized clinical trials designed to really look at time to clinical worsening as opposed to death. And the penultimate one in 2013, also held in Nice, where we saw updated classification, many more gene mutations, and that's going to carry forward into this one. The inclusion of pulmonary vascular resistance in the hemodynamic definition of PAH at that point mandated right heart catheterization for diagnosis, because too many people were being diagnosed with echo, which really doesn't have the best specificity for PAH. And at that point, right heart catheterization was mandated. And again, treatment and algorithmic goals were updated. Just a quick overview in terms of what we know pulmonary arterial hypertension to be. This is a disease of the heart and lungs that ultimately leads to exercise intolerance. As plexiform vasculopathy begins to destroy the pulmonary arterioles, pulmonary vascular resistance will worsen, creating both right heart failure as well as ventilatory inefficiency, and ultimately exercise intolerance. So we know that as PH progresses, what will happen is that there will be more and more plexiform vasculopathy and more pulmonary vascular resistance that will always worsen over time. Cardiac output falls in response to this when the patient is unable to compensate for higher resistance. And as a function of cardiac output, pulmonary arterial pressures, and pulmonary vascular resistance in the flow equation, you can see that pulmonary artery pressures will initially increase until patients begin to decompensate and then decrease. So it is a fallacy to look at pulmonary artery pressures on echocardiogram and see that a dynamic change from a higher pressure to a lower pressure always means the patient's getting better. You can see here that they may actually be getting worse. And really what we care about are things like right atrial pressure and right ventricular function as a determinant for where people truly are on this cardiac output curve. In terms of what's new with the definition of PH, let's look at the old definition really quickly and review that the definition of pulmonary hypertension just means that pulmonary artery pressures are elevated above 25 millimeters of mercury. The term pulmonary arterial hypertension applies to that pulmonary hypertension diagnosis, plus the absence of left atrial hypertension based on a wedge pressure or a left ventricular end diastolic pressure less than 16, okay? And again, like we talked about at the 2013 World Symposium, it included pulmonary vascular resistance greater than 3 Wood units to mandate invasive hemodynamic investigation to make this diagnosis. Where does 25 come from? It comes from even before the World Symposia, the World Health Organization Expert Committee on Chronic Cor Pulmonale in 1961, at which point they had said that mean pulmonary artery pressure really doesn't exceed 15 millimeters of mercury at rest in healthy people. It's little affected by age, so even old people should expect to have a low PA pressure and generally never exceed 20 millimeters of mercury. So to be extra sensitive back then, in the first World Symposium in 1973, pulmonary hypertension was really arbitrarily defined as a mean PA pressure greater than 25 because patients on Aminorex at that time typically had very severe elevations in mean PA pressure once they were identified, well beyond 25. So we knew that we were trying to catch as many patients as we could and not bringing patients into the fold that really didn't have the disease state. But as we move forward, we have more and more data about what a normal PA pressure truly is. If we look at healthy subjects from all over the world in multiple studies, you can see that the average mean PA pressure is about 14 with a standard deviation of 3.3, and a mean wedge pressure is about 8. So if we look 2 standard deviations down the road, even knowing that these PA pressures are preserved across demographics, we should assume that a PA pressure of about 20 makes sense, 2 standard deviations above 14, but it still doesn't account for where that range of 20 to 25 fits. What we know about is that during exercise, PA pressure should still be low, less than 20, unless you're getting older. In that case, there is a little bit of stiffening of the arteries, but with an increase of cardiac output along with that, pulmonary vascular resistance should remain normal. So even in exercise, we're still looking for pulmonary vascular resistance, even if PA pressure is going up a little bit. But it's still important to recognize this gap between the upper limits of normal, 20, and the lower limit of abnormal, 25. There's a real gap here, okay? When we look at this population of people, we can look at this in a couple different ways. And looking at a retrospective cohort of patients out of the VA actually investigated this population of people with mean PA pressures between 19 and 24 and found that those patients were showing up in the hospital more often and they were dying much more frequently. So you can see that there is a little bit of divergence between the lines here of a normal mean PA pressure in that in-between zone here. Hazard ratio for mortality begins to diverge a little bit before 20 millimeters of mercury. We look at another retrospective cohort in terms of increasing mortality at a PA pressure of 19 to 24. If we look prospectively down the road, 61% of those patients, when they're found to incidentally have mild elevated PA pressures, will go on to develop pulmonary hypertension on repeated investigation. And looking prospectively at patients in terms of mean PA pressure between 17 and 20 versus 21 and 24, we're still finding decreased physical capacity on cardiopulmonary exercise testing. And we found that mean PA pressure of 21 to 24, that in-between area, is an independent predictor of death. So 20 to 24 does not seem to be the area of health that we thought it was, and that cutoff of 25 may need to be adjusted here. Again, you can see from this study where the lines diverge here in terms of overall survival. this was enough information at the last World Symposium to steer away from the previous arbitrary cutoff of 25. And the new definition of pulmonary hypertension now observes the upper limit of normal, which was that mean or average mean PA pressure of 14 plus 2 standard deviations. And the new definition of pulmonary hypertension, at least by hemodynamics, in terms of clinical treatment, that's going to have a little bit of a different story. But in terms of hemodynamics, pulmonary hypertension is now defined as a mean PA pressure greater than 20 millimeters of mercury. Precapillary pulmonary hypertension, including what you know to be group 1 PAH, is still defined by the same wedge pressure and PVR cutoff. But in the hemodynamic diagnosis of precapillary PH or PAH, that's going to require a mean PA pressure greater than 20, a wedge pressure less than 16, and a PVR greater than 3 Wood units. And when we look at this in terms of our definitions of how we sort out each group, again, you can see that precapillary PH is just what we talked about. And precapillary PH will define clinical groups 1, 3, 4, and 5, everything but group 2, or group 5 if you're in a high output state. When we talk about group 2 pulmonary hypertension, just due to high left atrial pressures, that is isolated post-capillary PH. And again, defined by the same sort of pH cutoff, also with a wedge pressure now greater than 15, and a PVR less than 3 Wood units now defines isolated post-capillary PH. When we talk about the coexistence of multiple comorbidities on both the right and left side of the heart that may involve combined pre- and post-capillary PH, previously we were looking at things like transpulmonary gradient to determine whether pulmonary hypertension was out of proportion to its left heart disease, or things like the diastolic gradient to see what the true resistance across the pulmonary vasculature is. We've been able to reduce this and say that with very high wedge pressures, we don't know exactly what to do with a negative diastolic gradient. And now this has been refined to say that a definition of combined pre- and post-capillary PH really only meets the definition of pulmonary hypertension and a PVR cutoff greater than 3. There's no such thing as a diastolic pulmonary gradient or the term out of proportion PH anymore. We just use PVR with evidence of both combined pre- and post-capillary PH to say that that entity is there. And that's a little bit different than before. You're all used to seeing this table in terms of the World Health Organization groups of pulmonary hypertension. Nothing has changed in the actual grouping. However, there are some nuances to each disease state that we need to talk about. In terms of what counts as heritable PAH now compared to 2003, where just the BMPR2 mutation was isolated, there have been many different gene mutations isolated at this point. So we're always looking for a family history of pulmonary hypertension, which may complicate up to 25% of idiopathic cases if you're not looking hard enough. And when we talk about familial PH, in people that were thought to be idiopathic, these patients generally present younger and ultimately do worse, which is why it's really important to still be screening for any evidence of heritable PAH and referring them for a whole host of gene testing at this point, if indicated. When we look at drug and toxin-induced PH, there's a long history of this. Obviously, the first World Symposia were held in response to diet pill crazes, both the Minarex in the 70s and fenfluramine in the 90s. However, as time has gone along, we've seen other sorts of issues. And those other sorts of issues are, number one, the abuse of methamphetamine has really come to the forefront in front of diet pills of causing drug-induced PAH. There, every so often, are other sorts of drugs that fall into the possible column. Before 2018, we had many different sorts of stratifications of drugs. There was definite, possible, probable, maybe, kind of maybe, and maybe not so much. Now there's just definite and possible. So you can see where things fall in here. And some of the other things that are important to know for the purposes of real life, cocaine and amphetamine definitely fall in here. For the purposes of trivia and board exams, toxic rapeseed oil describes a type of canola oil that's been adulterated with aniline dye to be sold as high-quality olive oil in tourist ports in the Mediterranean. So poisoning from getting bad tourist oil is what that describes. And really the important things for clinical medicine these days are the increasing use of tyrosine kinase inhibitors for various cancer treatments. Dasatinib is going to be the most famous one for the development of pulmonary hypertension. So things to look out for really in the newest era of cancer treatment are the tyrosine kinase inhibitors. You can see dasatinib under definite, and bosutinib is really falling into more popularity these days. Schistosomiasis is, again, the most common cause of pulmonary hypertension throughout the world, always something important to know for board exams. We've redefined pulmonary hypertension in terms of the ability to get away with the use of calcium channel blockers. We know that when we do vasoreactivity testing, that some patients may qualify for high-dose calcium channel blocker therapy based on their ability to respond to a vasoreactivity trial. That's a minority of patients. About 12% of patients will respond to calcium channel blockers. And out of those 12%, only about half of them will stay as good responders 6 months down the road. So these patients have to be followed very closely with repeat right heart catheterization to make sure that they're remaining in functional class 1 or 2, and that they're remaining with good hemodynamics on that therapy. And then we'll classify them as this group 1.5 as PAH with long-term response to calcium channel blocker therapy. Some of the really rare zebras within this group of zebras is pulmonary hypertension with PVOD, or pulmonary veno-occlusive disease, or the other entity, pulmonary capillary hemangiomatosis. These are treated very differently. The only real treatment we have available for these patients is lung transplantation. And in parts of the world where this is very respected as a true indication for lung transplantation, centers in France will tout that they can get their patients transplanted in 72 hours for this disease once they're listed. What we need to look for in our patients who may have a high pretest probability of PVOD are a few different sorts of characteristics that may stick out. And this is a testable question on pulmonary boards. So PVOD does fall within the realm of testability. So I feel it important to go through. When we look at the pulmonary function testing of this subset of patients, they typically have very decreased DLCO. It's very depressed, usually lower than 50%. The typical is a 50-year-old with a DLCO under 50. So somebody who's younger than 50 years old with a low DLCO, the 50 under 50 rule kind of fits for someone we need to be looking at. The chest CT findings are predictive of what you'd expect to find in somebody with congestive heart failure, but a normal left atrium. So when people have congestive heart failure on CT, we're used to seeing septal thickening, mediastinal lymph node involvement, centrolobular ground glass or nodules that may indicate pulmonary edema, but really with no evidence of left-sided pressures because the lesion is in the pulmonary veins. The response to pulmonary hypertension therapy is horrific. The patients go into pulmonary edema because they have this decreased RV afterload into a blocked venous system, leading to pulmonary edema. And at that point, patients can even get so sick so quickly that they can die on the cath lab table. So trying to identify these people beforehand is really important. In the last few years, we've isolated the gene mutation that's responsible for the vast majority of patients with PVOD. That's the DIF2A-K4 gene mutation, and that is testable at this point. The other things to know about is around the world, the occupational exposure to trichloroethylene does put people at risk for this entity as well. In terms of group 2, the focus is by far and away on heart failure preserved ejection fraction, in which pulmonary hypertension may complicate up to 86% of cases. So that got moved up, actually. Preserved EF got moved to group 2.1, and reduced EF got moved down to 2.2, honestly, for no reason whatsoever. And really, the decimal point here really shouldn't have anything to do with the prevalence of the disease, but it was moved. We also look out for things like valvular heart disease and acquired cardiovascular conditions that lead to post-capillary PH. That's becoming very important as we're able to treat sicker people with transcatheter valve replacements. When we look at group 3, there's always a little bit of movement. There's always a little bit of debate about who should be in group 3 and who should be in group 5. The agreement at the World Symposium was to move lymphangioliomyomatosis from group 5 to group 3 because it does appear to be a diffuse parenchymal lung disease with chronic hypoxemia without a lot of other systemic effects in terms of the things that are associated, like tuberous sclerosis. So it's more of a pure group 3 disease at this point. Pulmonary Langerhans cell histiocytosis, on the other hand, is maintained in group 5 without a lot of debate, but the real controversy was whether to move sarcoidosis to group 3. And the reason why that was thought to be the case was that 80% of our sarcoid PH patients have scanning stage 4 chest x-rays, true pulmonary fibrosis, true hypoxemia. However, sarcoid patients can have any group of pulmonary hypertension that they well please, really because of varying amounts of sarcoid vasculopathy versus sarcoid heart disease leading to left heart disease in group 2. Group 3 is on its own. There can also be mediastinal lymphadenopathy to the degree that there's extrinsic pulmonary artery compression, essentially leading to a group 4 type case. So because sarcoid can do anything it wants, it gets to stay in group 5 for now. So the take-home points for the first part of this talk here are that PAH is now redefined by a mean PA pressure greater than 20, at least hemodynamically. We need to realize that this is based on retrospective data on mild and mildly symptomatic and healthy patients, but there's really not a lot of implication because we don't have a lot of study on patients with PAH that fit into the population with how they do with drugs. Do they do better because they have mild disease with drug, or do they just suffer more side effects because they're really not that symptomatic and the drugs cause a lot of side effects? We need new clinical trials to figure this out before we move forward. So for the insurance and the drug companies and all that, the treatment thresholds are for the most part going to stay at 25. However, the hemodynamic definition based on what we know the natural history to be is changed. Isolated post-capillary pH and combined pre- and post-capillary pH are better described now with PVR cutoffs than what they were before. We talked about familial PAH and looking for genetic causes being important. There is an increasing role in specific gene mutations. Generally, the BMPR2 analysis, but focused gene panels can be done, or whole genome sequencing can be done when your suspicion is driving one way or another. And the new classification does change a couple of different PAH subtypes. With that, we'll move into the diagnosis of pulmonary hypertension, which is important to know for our daily practice here. Let's start with what's not new in the diagnosis of PAH. PAH is rare. Pulmonary hypertension is endemic. Okay, so PAH is difficult to diagnose because there can be masquerading disease groups or combined phenotypes. You know, it would be very common to have someone with a little bit of pre-capillary, a little bit of post-capillary. These are your HFpEF patients that show up with COPD and sleep apnea. And can be really difficult to make sense of. So misdiagnosis is pretty common, and it does impact treatment. The current trials that we have continue to show lack of benefit for vasodilator therapy in group 2 and group 3 PH. So we want to make sure that we have real diagnostic ability here and that we're treating the right people in the right way. Going through the diagnostic algorithm can help distinguish these different patients to figure out when referral to expert centers is indicated. When you guys go out into practice, if you're into private practice, when is it indicated to get someone to a PH center of excellence? So the pitfalls in pulmonary arterial hypertension diagnosis are predictable. PAH is a diagnosis of exclusion. If we're jumping too quickly into the diagnosis, we're liable to get it wrong. We want to make sure we're not missing heritable causes. We talked about that a couple slides ago. Missing the drug and toxin-induced causes because cessation of therapy, or cessation of drug abuse can be its own treatment. Having a low suspicion for PVOD gets you into trouble if you're not looking for the pretest probability markers on PFT and CT. Missing congenital heart disease is very important here. The most common congenital heart diseases are atrial septal defect and partial anomalous pulmonary venous return that ultimately just don't do as well with our treatment without addressing the underlying problem. Not identifying left ventricular diastolic dysfunction. Again, pulmonary hypertension endemic in that population. And those people can masquerade as different types of pulmonary hypertension depending on their volume status that day. So thinking about pretest probability for that is something we're going to spend a little bit of time with here. And underestimating chronic hypoxemia or underestimating the contribution of group 3 disease gets us in trouble from time to time as well. So this is the newest diagnostic algorithm that is facing the primary care, the primary pulmonologist when an unknown patient comes in with history or symptoms or testing suggestive of pulmonary hypertension. So the things to look for history and clinical wise that we want to know about that might want to expedite referral to a PH center would be a family history of PH, drug and toxin abuse, connective tissue disease definitely, and there are some screening recommendations for some of our scleroderma patients mostly that we should be screening those patients regularly. Patients with a history of HIV do have a higher risk than the general population by about 25 times of developing pulmonary hypertension. And patients with a history of portal hypertension being evaluated for liver transplant should also be investigated. Again, if you have the usual suspects here, left heart disease, chronic hypoxemia, history of blood clots, that kind of factors in as well. The basic testing you all know about, chest x-ray, EKG, PFT, if there's abnormal findings on echocardiogram or VQ, those should all lead to referral to an expert center, okay? Who do we screen at this point? If we screen every person in the United States for an incredibly rare disease that occurs in 15 in a million individuals, we're going to waste a lot of money, but there are people that should be screened. Most importantly, it's the scleroderma population. We have algorithms available that help us predict when screening would be indicated. The DETECT algorithm is the most famous out there, but also PFT findings as a predicted FVC to predicted BLCO ratio greater than 1.6 or rising pro-BNP levels would all be indications to screen patients for pulmonary hypertension. In the modern era, HIV may be complicated by pulmonary hypertension in 2% of cases, but it would be very uncommon these days for us to diagnose incident PH and, incident HIV in a patient showing up to our clinic with PAH. So again, do we screen everyone for HIV at this point? No, not necessary. Only if more than one risk factor is present. Those risk factors are being female, having a history of IVDA or cocaine abuse and Hep C. Any two of those put together, you get screened for HIV at this point. Heritable causes, we spent a lot of time talking about gene mutations here. There is a national database of genotyping that we're always adding more and more information to pick up these different gene mutations to screen for. Hereditary hemorrhagic telangiectasias or the Osler-Weber-Rendu syndrome does have indications for screening that will generally cause high output heart failure and combine pulmonary hypertension with it. And portal hypertension, if the TR jet is greater than 3.4 meters per second, suggesting a high right ventricular systolic pressure, then those patients are typically reviewed for portal pulmonary hypertension if worsening cirrhosis or planning for transplant. Also, patients with repaired congenital heart disease do deserve longitudinal screening for the development of pulmonary hypertension as well. Okay, so when we look at any of our echoes, we try to determine what's the probability of having PH that needs to be dealt with. Where we start is the peak tricuspid regurgitant velocity. This is what we're calculating right ventricular systolic pressures off of when added to the right atrial pressure. So if you have a low TR jet, really no probability of PH here. Once you get up into the area of 2.9 to 3.4 meters per second, depending on whether there's other signs of PH on the echo, and we'll talk about those in just a second, you might have an intermediate probability of PH. And once you get really high, then yeah, you got to look further. What are the signs of PH on echo? In terms of the ventricles, right ventricular dilation, a right ventricle that's bigger than the left ventricle is a dead giveaway. Evidence of right ventricular pressure and volume overload, as seen in flattening of the intraventricular septum, either in systole or diastole, to determine pressure versus volume overload, are important to look for. Pulmonary arterial dilation, if you're dilated more than 2.5 centimeters, is something to look for. The other thing we look for is RV outflow tract Doppler morphology for mid-systolic notching, or a pulmonary velocity acceleration time less than 105 milliseconds suggests that there is actual pulmonary arterial resistance that the right ventricle is trying to pump against. We look at the collapsibility of the IVC as well as really the right atrial morphology to tell us is there right heart failure here as well. So if you have signs from two of these categories, we're going to talk about high-risk pretest probability for PH. Important to look at differentiating group 1 from group 2. Again, the entire iceberg here is going to be group 2. It's left-sided heart disease, and the real tip of the iceberg is your precapillary stuff that deserves extra treatment, including PAH and CTEPH. This is a population of Western Australia where there's only one echocardiographer doing all the studies. So out of 4,000 patients, 400 of them had a PA pressure greater than 40, and these were the final diagnoses that you can see here. By far and away, left heart disease. There's a lot of different echocardiographic findings that help us triage, is someone left or right heart failure? And again, by far and away, the vast majority of these people are going to have left-sided heart disease. So when we triage echoes in this clinic, we're always looking to the left atrium to see is there evidence of left heart failure here. So that's always the first place we look. We're not looking at the PA pressure. We're looking at the left atrium first. Then we're looking at the right ventricular function. And probably the last thing I look at on an echo is the PA pressure. But really look to the left atrium as the rule of thumb here. So again, differentiating group 1 from group 2 PH has everything to do with the wedge pressure and the PVR. What do we do with this? What's normal for a wedge pressure? It's about 11 for the upper limit of normal. 8 was the average PA, or I'm sorry, the average wedge pressure and seen in large groups of people. The upper limit of normal is 11. The diagnostic definition for PAH is a wedge pressure less than 16. So again, we've got the sort of middle ground that we're always worried about. You know, are we missing patients or are we misclassifying patients based on mean PA pressures of 20 to 25? And the same story goes along with wedge pressure too. If your wedge pressure is between 12 and 15, what are we really dealing with here? We know that these patients, when they're diagnosed with PAH at a wedge pressure of 12 to 15, they just don't do as well. It kind of raises suspicion for the possibility that there was a occult left heart failure there. So did heart failure with preserved ejection fraction go unrecognized when this patient was Cath because they came in either euvolemic or hypovolemic? They just been diuresed on the hospital floor, perhaps over diuresed, and now they look dry and they look precapillary, when really they do have occult left heart failure. And we've got a couple of rules of thumb to help figure out what to do about that now. So our thought process when taking people to right heart cath really comes along with the pretest probability of left heart disease. And I try to look at each of these for any right heart cath that I order. What's important to look at is probably the low probability person, the 19-year-old with lupus. If she's got PH, she's got PAH probably. But things like age factor in. The presence of the metabolic syndrome factors in as a high risk for HFpEF. Having cardiac interventions before, having a cardiologist before, having atrial fibrillation, having valvular disease are all sort of important markers. When we go further down into more and more invasive studies, we can see that there's still things that we can pick out. If you have an EKG that shows a left bundle or left ventricular hypertrophy, this is probably left heart disease. If you have normal signs or signs of RV strain, this is probably PAH. On echo, same story goes. We're looking for left atrial dilation in grade 2 diastolic dysfunction or greater. If you're not seeing that, we got to start thinking more about right-sided failure for PAH. When we look at cardiopulmonary exercise testing, there's also markers that can show us whether there is left-sided heart disease. Things like a not so bad bed-space ventilation, or the presence of exercise oscillatory ventilation would suggest more left heart failure. If you're seeing a very high VEV-CO2 slope, that's going to suggest more dead space ventilation due to pulmonary arterial hypertension. And cardiac MR shows us a lot more information about how a left heart is functioning. It can show us that there's a high probability of left heart failure. So what do we do with that information once they're in the cath lab? Well, if a patient shows up to a cath lab and they've got a wedge pressure greater than 15, and they were high probability to begin with, then you make your diagnosis. This is left heart failure. If their wedge pressure is if their wedge pressure is greater than 15, but they were low probability, if it was still someone who is of low probability, but the wedge pressure is high, but what if they're a 19-year-old with lupus and you've got high wedge pressure? You really should think about confirming that with a left ventricular end diastolic pressure, because although cuff test is still likely, if the wedge pressure is overcalled and the left ventricular end diastolic pressure is very low, you should recalculate that and make sure that you could have group 1 PAH still. So pretest probability really fits into what to do with these abnormal values when you weren't expecting them. If you got someone with that intermediate sort of wedge pressure, 13 to 15, the 19-year-old with lupus, she's confirmed. She's precapillary PH. She doesn't have risk factors for left heart disease. If you have intermediate or high probability for left-sided heart disease, but you have a normal, or what we would think would be normal or less than abnormal wedge pressure, you haven't excluded HFpEF yet, and you have to do something to provoke them. Typically what we would do is we would offer volume challenge. And in the most recent World Symposium, we've standardized that to say that it affects the volume challenge is 500 cc's of fluid over 5 minutes. That bumps the wedge pressure to greater than 18. If you can prove that, you've induced more left-sided failure than right-sided failure, and the patient has HFpEF at that point. If you can't prove that, then they've got PAH, but we know that patients with wedge pressures 13 to 15 just don't do as well because they do have high pretest probability. So we call that term PAH with cardiovascular risk factors. You're looking at them as a little bit of a separate population in terms of what to do with those patients when it comes to drug therapy. Other sorts of provocative testing that we can do would be invasive CPET or exercise right heart cath to determine whether these people will bump their wedge pressures with exercise. So in terms of getting good right heart cath numbers, the validity of a wedge pressure can be difficult. You really have to know what you're looking for in the tracings. But some of the key rules should be that your pulmonary wedge pressure should be less than your diastolic PA. If it's not, you got some problems going on here. Or you just have really bad left atrial compliance or bad mitral stenosis. But all those things need to be thought about. The tracing should be compatible with an atrial pressure waveform. We know that the wedge pressures look a lot like RA pressure waveforms. You may want to check fluoroscopic position, showing that the catheter is not whipping around. If you inject a little bit of contrast in there, you would see contrast not moving forward because there's no flow behind the catheter. The other things that we can do are we can check wedge stats, and if you're seeing good oxygenated blood coming out of a wedge catheter, then you know that you're effectively wedged. If you're getting mixed pulmonary venous blood in there, then you're not adequately wedged. Wedge pressures, again, should be measured at passive end expiration so that there's no effect from high intrathoracic pressures within the chest. And it should be averaged over several cycles, not just one pressure reading in time. Again, we talked about the fluid challenge as a wedge pressure greater than 18 after adequate fluid loading. And exercise-induced pulmonary hypertension would be defined as mean PA pressure greater than 30 and a cardiac output such that your PVR would go above 3. How do we differentiate group 1 from group 3? This is really important in our practice as we see all sorts of diffuse parenchymal lung disease. So it's a common cause of precapillary PH. And it's really more of a difficult diagnostic dilemma compared to left heart disease, where there's typically a high wedge pressure and a huge pretest probability. And even in this era, it can be unclear to us whether PAH is occurring with a common comorbidity. Just a little bit of COPD or sleep apnea is not going to cause PA pressures out of proportion to what we're used to seeing. But there's also a possible vascular phenotype or a vasculitis that goes along with a very small subset of patients with COPD, probably about 4% of your bad COPDers that really don't have bad depression in their flows, but just have horrific diffusion, suggesting an additional phenotype. But it's still unclear to us if this is comorbid or if there's a subtype of disease that has just a huge vascular inflammation phenotype. All of the data that we have up to date do not really support treatment of group 3 PH with vasodilator therapy. And we have to use current tools that we have available to help risk stratify who's going to benefit from therapy and who's not, because COPD is so commonly comorbid. So what do you do if there's someone who has limited chronic lung diseases here? If you got obstructive disease and your FEV1 is above 60%, you might be treatable. If you have restrictive diseases with a vital capacity that's greater than 70% predicted, you might be treatable. And if really you're not seeing a lot of parenchymal change or desaturation, then this might be more of someone who has group 1 PAH with comorbid lung disease. Those patients typically benefit from therapy. Now, what do you do if they're severe, though? If they're obstructed beyond 60% or restricted beyond 70% with extensive CT changes, they need to be looked at in a center that typically has all of what we have here in terms of a PH and ILD and transplant centers. And if your PH is mild to moderate, as in you're really not suffering from heart failure as much as you are from ventilatory failure, we're typically not treating those patients, but still evaluating for transplant. If your heart failure is so bad that you're not going to make it to transplant, then we do try to individualize care to address the heart failure part of this while patients wait for transplant. And you've seen that from time to time here. Otherwise, this is a different way of looking at it in terms of the differences between the group 1 phenotype versus the group 3 phenotype, and really to focus your attention at this point on cardiopulmonary exercise testing. Again, the things that are going to figure into group 1 versus group 3, looking at dead space ventilation and looking at breathing reserve are really two big ways of seeing things. And we always are looking for the presence of excessive end-tidal CO2 during exercise, because that may help you differentiate as well. So the take-home points on this one are that patients may have group 2 and group 3 comorbid contributors of variable significance. We've got algorithms that help us predict the pretest probability of whether these conditions are really favoring more so in the patient's presentation. And even during testing, we can fluid load or exercise challenge to help parse out who is who. Additional studies in the lungs in terms of PFT, cardiopulmonary exercise testing, are really helpful as well in terms of finding out who benefits from therapy and who benefits from ongoing optimization of their lung disease. More pictures from France. We have a few minutes. I just want to keep barreling through here. In terms of the treatment of PAH, what's new? Well, not a whole lot. We don't have any new drugs since 2014. The trials are ongoing, and the trials really are getting better in terms of what we're doing to compare monotherapy or sequential combination therapy versus placebo, and what we're doing to look at combination therapy now versus monotherapy. And the way we do our trials is also improved as well, in that we're looking for events that suggest time to clinical worsening at the composite, as opposed to a very rare occurrence of death at this point, to help us figure out who benefits and in what way. The old paradigm of how we used to treat these patients was pick a drug, and when they're not doing good, start another, until you've exhausted all three, and then think about lung transplant or septostomy. What's truly new in the treatment of PAH over the past 5 years is a difference in our treatment paradigm that show us that combination therapy really is helping improve clinical response. And the way we pick that combination therapy is based on risk stratification. So all sorts of clinical features, as you know, go into how we figure this out to really try to predict who is a low, intermediate, and high risk for 1-year mortality, and then choose our treatment based on that. So this is the newest treatment algorithm, and we'll go through it in a couple different pieces here. If you have a patient who is now just being confirmed as having pulmonary arterial hypertension, and they have idiopathic, hereditary, or drug-induced PH, we're doing calcium channel blocker evaluation with vasoreactivity testing. The definition of a responder is on the screen here, and that is easily testable on boards. If you're not vasoreactive, you need the fancy pulmonary arterial hypertension drugs. And at that point, we look at whether you're low or intermediate risk based on a risk classification. And there's two different ways to do that. And if so, you're getting dual oral therapy. If you're high risk, you're getting parenteral therapy and perhaps a referral to lung transplant. We follow our patients very closely, and at 3 to 6 months on dual oral therapy. If you're doing good, that's what we want, and then we'll keep you on that therapy. If you have not fallen into a low risk classification, we're looking at triple therapy pretty quickly. And if maximized on medical therapy, we're looking back at lung transplantation. That's that bottom part there. So in terms of risk stratification, again, You've seen this in our clinic notes. It comprises a clinical evaluation of evidence of right heart failure in amount of dyspnea, exercise testing, either submaximal with 6-minute walk test or with cardiopulmonary exercise testing, lab work indicative of RV function, imaging, and hemodynamics. And we choose where these patients fall in their risk category. This is a grade 1C recommendation in the 2015 guidelines, but it's based on expert opinion. We do have new registry data available that helps advance us to a higher recommendation. What's available? Looking at 3 different European registries. So these are 500 Swedish people with PAH. At incident diagnosis, the ones that are low risk do really well. The ones that are high risk, not so well. That's at diagnosis. If we look at them in follow-up, 6 months down the road, if we can get someone into low risk at 6 months, they do really well. If you can't move someone out of high risk, they do really poorly. And we can move the stratification and say that people that have improved from any sort of higher risk to a low risk, they do actually just about as well as people that started out low risk altogether. So really it's the drug therapy that helps us move into low risk that keep these people going. If we look at Eastern Europeans, you get just about the same exact sort of information there. And if we look at French people, about 1,000 of them, what's special about the French registry is that they were able to risk stratify their patients based on very non-invasive testing, symptomatology, 6-minute walk distance, and a BNP level. No repeat Cath, no repeat echo, no cardiopulmonary exercise testing, none of that, just very non-invasive things. And if you can meet all 3 of these criteria, just about 95% of these people are alive in 5 years. So that's pretty good these days. In America, we have a little bit more of a complicated strategy called the REVEAL risk score. So different ways of assigning points to different clinical features that gives you a score. And this scoring system has been validated every which way to Sunday based on different cohorts. But looking at 2,500 American patients, there are multiple strata that go along with this. So not just the low, intermediate, and high risk, there's multiple subtypes here, but again, very similar data in terms of who does what. We need prospective data based on our current treatment. And it's unclear if all of these strata really are helpful clinically. Blue intermediate versus gray intermediate, we're kind of unclear as to what the difference is there. In terms of the other sorts of features of PAH treatment, if you're lower intermediate risk, you're going to get dual oral therapy with an ERA and a PDE inhibitor, but the specific combination of Ambersen and tadalafil is known to be efficacious based on the Ambition trial from 2015. This trial showed improvement in time to clinical worsening. There is some role for monotherapy, but very rarely. The Ambition trial is important to know about. These were 500 patients who had functional class 2 or 3 symptomatology, randomized to combination therapy or one or the other with a placebo. The primary endpoint was time to clinical worsening, which was death, hospitalization, disease progression with the need for transplant, or an unsatisfactory long-term response over 6 months. And you can see that in the combination therapy group, these patients did much better than the pooled monotherapy group. And compared to pooled monotherapy here, combination therapy is so much better than just one drug alone. It's important to know that the real thing that was driving the time to clinical worsening events was hospitalization. but there is a big improvement in the frequency of hospitalization with these patients with this use of therapy. There is a role for monotherapy in people that are relatively low risk, or people that are on calcium channel blocker therapy, people that have been on monotherapy forever and are doing just fine, people who are relatively old with cardiovascular risk factors, stabilization of PVOD in very selected cases. HIV, portal pulmonary patients are not typically included in the combination therapy trials, and single therapy may be indicated there, or very mild disease. Or if you're in a place or in a country where you don't have the full complement available, or liver disease that contraindicates other drugs. Okay. Last piece of the puzzle is high-risk patients. If you present high risk, you are offered parenteral prostacyclin, and typically we're thinking about transplant if any signs of PVOD is present. If you are high risk after 3 months of treatment, we're typically evaluating for lung transplant at that point, and offering triple sequential therapy there. So the last slide here is just the take-home points for this last section, is that new clinical trials are ongoing for robust and meaningful clinical endpoints. Risk stratification is very important in what we do, and guide the aggressive therapies for the combination drugs that we use, as there are no new drugs on the market over the past 5 years here. Parenteral prostacyclin therapy for high-risk patients should be considered, as should early referral to lung transplant. And that's all I have for you. About 5 minutes left for questions.
Dr. Kelly?
Yes.
Hey, this is Raj. I was just curious, for the exercise right heart cath, is it that they just put a swan in and have the patient run on a treadmill or a ergonomic bicycle and just measure the weight?
Yeah, so a couple ways to do it. There is kind of the lowest cost way to do it is to lift saline bags and exercise. The more fancy ways of doing it are cycle ergometers. So whether that is leg pedals or whether that is arm pedals, is usually the way to do that, just laying down on a cath lab table. And that's what we see more frequently when metabolic cart is added onto it. There are centers that protocol in an exercise bike and are able to move the patient with the right heart cath in situ and get up on a bike, and that's generally no problem. But just different centers have different ways of doing it. Ours is typically cycle ergometer at West Bloomfield with a metabolic cart.
Hey, Brian, this is Zach Morris. Can you hear me?
I can, Dr. Morris. How are you?
Okay, yeah, I just wanted to mention one thing in here. That was an outstanding talk, by the way. Just so everybody's clear that when in the guidelines that when they use the VE to VCO2 slope as a measurement, I think it's important to understand that that is not how we measure when we do cardiopulmonary exercise testing. We actually measure the VE VCO2 at anaerobic threshold. The reason we do that is the V-slope method is probably the most inaccurate way of measuring that number, but it's something kind of easy for people to do. But it does tend to often overestimate, underestimate what the actual value is. Whereas using the VE VCO2 at anaerobic threshold overcomes a lot of those measurements. I'm sure if you get old Dr. Lazar, when you guys do your rotation, kind of pay attention to that, because the cardiologists often use the VE VCO2 slope. They don't really understand it's fully dependent on the 0 point where you start, and there's some other measurements that could cause tremendous inaccuracies in it, an estimation. But pay attention to that on your rotations here, what the difference is between those two. Still there?
Oh, yeah, I'm still here. Thank you.
Okay, yep, that was it. Thank you.
Anyone else? Feel free to unmute or run into my office frantically. All right, thanks, guys.